Great. It's all yours. Okay, are we ready?
I believe so.
Okay. Okay. Elaine, feel free to ask any questions, interrupt me at any time if you would like to. So this is just a physical therapy aspect of how we treat our arthritis patients. And it gives a little bit of background about what arthritis is, safe exercises, and then some adjunct things you can do like bracing. And I think it goes a little bit into injections down the road. So like I said, feel free to ask any questions. So at the clinic, we have already developed a program called Moving Smarter with osteoarthritis. It's an online component for this class, and then there's also a nutrition class, but I'm sure you guys are covering a lot of that in here. So this PowerPoint is based off of that class. So we'll talk about what OA is, the causes of it, OA, osteoarthritis, common symptoms, risk factors, and then mechanical and rehab interventions. So this PowerPoint is tailored down to the knee, but obviously it can be any joint in the body. So the knee is the largest joint in the body. The different parts of the knee include the bone. So you have your femur, your tibia, and then your kneecap, your patella. You have cartilage, both with the menisci that sit in between and your articular cartilage. And basically what the cartilage is it acts as a cushion and gliding surface for movement. And it keeps the bones in the joint from rubbing together. And then you have both inside and on the outside of the knee, you have ligaments that provide extra support for activities. And like I said, they're both on the inside and the sides of the knee. Okay, so osteoarthritis, the most common form of degenerative joint disease. It's a leading cause of disability in people over 50. It tends to affect the load-bearing joints. So hips and knees are probably the most common that we see, and those are very crucial for your movement. So the osteoarthritic process is very gradual, with symptoms that may come and go and eventually worsen over a number of years. So it involves two primary processes: cartilage breakdown, which can happen from injuries. And we see that, but a lot of times we do see it from aging. So bones that, obviously you've heard bone on bone, and that makes contact and causes pain. And then small deposits of bone can develop called osteophytes, or what we call bone spurs, that may grow on the edges of the joint. Come in, take a seat. Okay, so this is just like a normal versus an osteoarthritic knee. So on the right side, you can just see this cartilage breakdown, and when this breaks down, along with that eroding meniscus, you have one both on the inside and the outside of the knee. That joint tends to close down, and that's where you get the bone on bone. Down through here is a little bit of bone spurring. So risk factors, biggest two: advanced age, and then excess weight and obesity. Other risk factors include joint trauma and then family history. So with advanced age, symptoms of knee arthritis increase at the age of 45 and beyond. Obviously, it increases with age, so knee joints experience wear and tear, and cartilage thins and becomes less flexible, making it more prone to that arthritis over time. Excess weight and obesity. So knees and hips are weight-bearing joints. So when a person is overweight or obese, it's significantly more likely to develop knee OA. 2 out of 3 people who are obese are likely to have developed knee osteoarthritis. So our biggest push with therapy, with strengthening, is also maintaining a healthy weight, because even a few pounds can significantly reduce the risk. And it said one study showing that losing as little as 11 pounds reduced the risk of developing knee osteoarthritis amongst women by 50%. Okay, so some other factors include joint trauma, so a broken bone, serious injury or surgery may cause damage to the knee joint that eventually leads to osteoarthritis. Symptoms may not appear until years down the road. And then osteoarthritis that develops as a result of previous injury is usually termed traumatic arthritis or post-traumatic arthritis. And then we talk about family history. So similar to height and hair color, the likelihood of a person developing knee arthritis is influenced by genetics. While the exact extent of genetic factors is not known, the CDC estimates between 20 to 35% of incidences of knee arthritis may be inherited. Okay, so symptoms of OA: knee pain, knee stiffness, inactivity makes it worse, and then knee swelling. Okay, knee pain, probably the most common report that we hear. The description of the pain will depend on the condition and the situation. It varies from dull, toothache type pain versus really sharp, intense pain, dependent on activity level. So walking the stairs, we hear a lot. Bending down to reach something, we hear a lot. And I will say, just anecdotally, walking both up and down the steps, but more often down the steps hurts more. And then it decreases with rest and ice typically. Knee stiffness, so bone friction and swelling in the joint makes the knee stiff and less flexible. Experience only knee stiffness in the morning or after sitting for long periods of time, typically called that the movie theater sign. After you're sitting for long periods of time. Stiffness may or may not be accompanied by swelling, and then knee range of motion can become more limited. So a person with moderate to advanced knee arthritis may find it is difficult to straighten out their knee, and vice versa, bending it as well. But a lot of times we hear straightening is more difficult. So inactivity makes it worse. So stiff after sleeping or sitting for a long period of time. So our goal, and probably why you guys are here, is to keep moving. And last but not least, knee swelling. So when knee cartilage wears away, bones can rub together, resulting in irritation and swelling of the knee. So basically it's fluid built up in that knee, and can be accompanied by a sensation of warmth or burning. So diagnosing OA. Most individuals over age 50 will have signs of arthritis, osteoarthritis in their major joints that can be seen on an X-ray, but most will not have symptoms. No single test that we have can definitively diagnose osteoarthritis of the knee. Doctors typically use a comprehensive approach, so X-rays, your medical history, and then a physical exam by a healthcare professional. So on that left side, you can see a healthy knee, really good joint space in the medial and lateral compartments. And then when you look at the right here, this would be where the arthritis is on the medial aspect. So our goals as therapists, number one is to control pain. And then improve joint function, obviously what we talked about earlier, maintaining a normal body weight. And then even without having arthritis, our goal as physical therapists is for patients to get their symptoms under control and then be independent with a gym strengthening or home strengthening program. Because we want you to be healthy and exercise for the rest of your life. Okay, I gave you the answer here, but exercise will aggravate your joint pain and stiffness. So obviously that's false. What we do is we give you exercises that help strengthen and build muscles around the OA affected joints, easing the burden on those joints and reducing pain. So range of motion exercises help maintain and improve joint flexibility and reduce pain. True or false, lack of exercise actually makes your joints even more painful and stiff. That's true. So in fact, inactivity is harmful and often leads to other health problems. True or false? Keeping muscles strong is crucial to maintaining support for your bones. True. Not exercising weakens those supporting muscles, creating more stress on your joints. And then we're going to talk about a little bit about OA treatment and interventions. So physical therapy and exercise, what we do is we try to develop a graduated and targeted knee strengthening and stretching exercise program for the treatment of knee OA. So here's a couple benefits of exercise. So heart and lung efficiency, obviously reducing your cholesterol, blood pressure, increasing strength, weight loss, reducing stress, increasing energy, improving sleep quality, increasing mental acuity, improve appearance, reduce risk factors of illness. This is a big one for everybody I treat, improving your posture, which I think makes a huge difference, increasing stamina and reducing injuries. I don't think this is the case for you guys, but we hear this a lot. A couple of reasons why people don't like to exercise. We hear, I'm too young to do it. I'm too old to do it. This is probably the most common one. I'm too busy or I'm too tired. And that they think they're already in good shape. So our first steps as a physical therapist is just to evaluate how fit you are for your chosen physical activity. So we always want you to consult a doctor before starting physical therapy, just to kind of rule out all of the major health risks. And we're kind of looking at the age ranges of 45 plus for males and 55 plus for women. In that arthritis frame. So keys to lifetime fitness, obviously choose activities you enjoy, set realistic goals, tailor your program to your fitness level, give it some time, build in rest days, and listen to your body. Okay, so just some key components to fitness. We have cardiopulmonary endurance, muscular strength, muscular endurance, and then flexibility. So your cardiopulmonary endurance, that's what improves your heart health and your activity tolerance. So swimming, biking, walking is huge, elliptical, running, anything that's going to increase that heart rate. The second part is muscular strength, so ability to exert force for a short period of time. No, with this class, do you guys go out to the gym at all? Are you guys? Yeah, so yeah, perfect. So machines, free weights. I really tell somebody really whatever they enjoy compared, like free weights compared to machines. Muscular endurance, so ability to perform exercises multiple times. And then flexibility. So ability to move joints through full range. Okay, so here's just some fitness basics. I'm sure that these guys have already gone over that with you, but include an activity from each of the 4 basic components, just some general guidelines, warming up 5 to 10 minutes, flexibility 10 to 12 minutes. I always tell my patients it's good to stretch every day. Cardiovascular endurance, 30 minutes most days of the week, and then muscular strength, 2 20-minute sessions each week, and then focusing on some major muscle groups. We have this conversation frequently with patients. Stretching is not a warm-up. So before you work out, we like to have you do some more dynamic activity than prolonged stretching. So knees to chest, butt kicks, shuffling, things that'll just warm up your muscles. Cardiovascular activity level, we always tell people start slow. Walking 20 to 30 minutes, 4 to 5 times a week is a really good start. We have something called the talk test. I don't know, do you guys talk about that? Okay, so This is just making sure that you can carry on a basic level of conversation without being too winded. So if you can easily sing a song, you're not working hard enough. But in that same sense, if you are out of breath and cannot even speak any words, you're working too hard. So just a basic level of conversation. All right, so 2 types of strength training. We have isometric strength training and then isotonic. Isometric is more of tightening or strengthening that muscle without joint movement. So they give an example of a quad set. That's one exercise we do in therapy. Whereas isotonic is probably what you guys are more familiar with. This is resistance training. So using bands, weight machines, and free weights. So you're moving through that available range. Balance and coordination. All components of exercise improve balance and coordination. It's a key to fall prevention. I always tell my patients our balance does not get better as we age. So if you're not working on balance now, add stuff in. I always tell patients the best thing you can do if you're standing there and brushing your teeth in the morning, try and balance on one leg, okay, while you're brushing your teeth, and then switch to the other side. Easy way to add balance in. And then balance also in turn works on strengthening, especially with your hips and your feet and your knees. Okay, so a couple of things of what you should expect when you start a fitness program. So exercise should not cause lasting pain. A little discomfort, a little soreness is to be expected as stiff joints loosen up in the morning. Some mild soreness when starting a new exercise, but you shouldn't be having like 4 to 5 days of pain after you work out. So if pain lasts more than 2 days, ease up on your workout to give your body a little bit more time to get used to the new exercises and recover. Lasting pain, you probably need to see your doctor. Activity modification, certain high impact activities should be avoided and alternatives may be identified. So, it's rare that we tell our OA patients to go out and start running on the treadmill or jogging on the treadmill. But cycling and swimming are really, really good options to replace that jogging, both of which exert less force on the knee joint or hips or ankles and feet. The conversation I don't like to have with anybody, but it's really important. So talking about your body weight and osteoarthritis. So for every extra pound on the body, an extra 3 pounds of pressure is exerted on the weight-bearing knee joint. So if you think about it, gaining 10 pounds can mean 30 pounds more pressure on the knees, as well as a significantly greater chance of developing osteoarthritis. If you guys, not that you two need to know, but if we do have patients that are concerned about that, we can always ask their primary care to consult nutrition through the clinic, and that's a good place to start. So weight loss in OA, a diet to maintain a healthy weight can pay big dividends for those suffering from knee arthritis. Losing weight will significantly reduce pressure and strain on the knee joint, thereby alleviating symptoms and perhaps slowing the progression of the osteoarthritis. So why exercise works? If your activity stays the same and your intake stays the same, you will gain weight as you age because your metabolism is slow. So this just talks about metabolism facts. So exercise increases your metabolism. Muscle uses more calories than fat does. Metabolism slows as we age, primarily due to a decrease in muscle tissue. And after 30, the body gradually loses muscle. Weight loss involves a combination of both diet and exercise. So seek professional help in your weight loss plan. If you have any questions about the Cleveland Clinic nutrition, please let me know. And then you cannot exercise your way out of a bad diet. Maybe you can at 15, but I'm 35 and I cannot. So, all right. So this goes into a little bit of mechanical treatments. So certain orthopedic products may be used to help stabilize or take pressure off of the knee. These typically alter the alignment of the knee during stages of walking. So we see two types. On that left is a genu varus deformity. So this leg is bowing out a little bit, whereas this is more of a genu valgus deformity where that knee kind of caves in. So a couple of mechanical treatments. Shoe and shoe inserts can lessen the pressure put on the knee when walking. If indicated, I'm a huge fan of custom orthotics, which we do here. We do have a couple of options for knee braces. Our most common is the unloader braces. So that alters the alignment of the knee during stages of walking to decrease pain. It helps stabilize the knee, and it provides pressure in a direction to decrease pressure on painful areas of the knee.
That particular brace.
Yeah. Correct. You cannot get these off the shelf. I will show you something in a second you can get off the shelf. The unloader braces we get fit for you because they have to measure like your quad and below the knee joint right around your calf. But this just kind of shows how it applies forces to unload the joint. So this just mechanically shifts the painful joint loads from the degenerative compartments to the healthy compartments. And then the hinge allows the ability for fine-tuning that load. So we do see some patients with this. I will tell you, sometimes it's more of a compliance issue. So if we have, it's so bulky. Right. And I would say it's probably, I don't know. I'm just throwing a number out here, maybe 50% of people I see with them. They're not like super common, but they are available. I think it's the next one that I see that's a lot more common. So this is just a picture of the brace on there compared to off. So it just shows how it shifts that weight over. This one is what I see more often. So I know upstairs Dr. Lear has these in stock, but I'm pretty sure you can buy it off the shelf. You can't see that picture on the right very well, but that's just a compression sleeve. But these elastic knee braces can support the knee joint. It's more of like a low profile unloader, and it decreases front-sided knee pain, so what we call anterior knee pain. So I will say that I see more patients with these. The other thing is the slide. So it's just one of those things that you have to keep pulling up and reattaching. But I would say there's more compliance with that. And that I'm pretty sure you can get off the shelf.
Is it lighter or
it's lighter than the unloader. It's definitely lighter than the unloader. It's a little bulky because this is not fabric. This was
not?
No, it's more like a silicone type. What is the word I'm looking for? But that's the type of material it is more silicone.
It's kind of plastic.
Yeah, but it's moldable, like it bends. I have patients who do well with just a knee sleeve, especially if they're having swelling. Just a sleeve that you can get at Drug Mart or CVS, throw it on, it alleviates some of the swelling and in turn alleviates some of the pain and pressure. So you don't have to get super fancy with these. Do you guys have any other questions about that one? No. All right, so we use neuromuscular stimulation, which is called NMES, in physical therapy. I will say we use it rare with our knee OA patients, but we can. It's meant to strengthen the quad by electrical stimulation. So we typically use it a lot more for like our ACL patients or our meniscus repair patients, but I have used it once or twice in the last 4 to 5 years on my knee OA patients. So all it is it's just a little device that attaches to the front of your quad and it kicks on kind of like a TENS unit, but much stronger to help contract that muscle. So it's really meant for patients who don't have good quadricep muscle strength, which is kind of the key of our rehab program is to strengthen your quad muscle. That's the extensor of the knee. So it's just kind of like a bonus if you're having trouble strengthening that muscle. This is the units that the clinic can provide. So one is actually a wearable unit. I will say I've not seen somebody with that, but I know we can order that. All right, do you guys have any questions? No?
What are some of the quadrants?
So we typically start people off with isometrics that we talked about a few slides back. So that's where if like your leg was straight, you're just starting with tightening that quad muscle. So pushing the knee back, tightening, holding for a couple seconds and relaxing. And that progresses all the way up to like a knee extension machine, if you guys can tolerate it. So that's where you're kicking the bar up and back down. Straight leg raises on your back. That's a huge one that I love. Squats, because they're so functional. And yeah, I mean, we'll progress people into like lunges and trying to think what else. Leg presses, those are really good too. So any of the above, anything that you can tolerate. So a lot of people can't initially tolerate that leg extension machine if they have kneecap tracking issues. But if you can tolerate it, I would say that's like the number one exercise I would give. All right, any other questions? I think that's it. Of course, of course. Just hit stop. Okay.
What is Thursdays?